You take about 20,000 breaths a day. It's, it's this sheer mechanical marvel of a process, right? Just a rhythm that runs completely in the background of your life, in, out,
Yeah, we really take it for granted.
completely. And we all know the basic anatomical pathway, like the air travels down the trachea through the branching bronchioles and finally reaches the alveoli.
Right, the tiny air sacs.
Exactly. But the real magic, and honestly where the system is most incredibly vulnerable, is at the capillary alveolar membrane, because that is where oxygen has to physically cross over into your bloodstream.
So that 97% of it can bind hemoglobin and actually keep you alive.
Right. And you probably never even think about that delicate pressure gradient until the exact moment it, stops working.
And when that membrane fails or when the pathway to it is obstructed, it triggers, honestly, one of the most terrifying physiological cascades a human being can experience.
Which brings us to our deep dive today. We're looking at this extensive clinical lecture on gas exchange.
It's basically a masterclass in medical prioritization.
It really is. We are going to decode not just the pathophysiology of respiratory failure, but the very specific step-by-step nursing interventions and the clinical rationales that healthcare providers use to keep patients breathing when everything goes wrong.
Because there is a very strict logic to how you save a failing airway.
Absolutely. Okay, let's unpack this by starting with what happens when the lung architecture just kind of slowly degrades over time. We hear the term COPD tossed around a lot, chronic obstructive pulmonary disease.
Right, but looking at the clinical breakdown, COPD isn't just one single thing. It's an umbrella term covering two very different battlegrounds, emphysema and chronic bronchitis.
Let's look at the underlying physiology of how these physically alter the human body, because it's wild.
It is. So emphysema is fundamentally
Yeah.
Exactly. Normally, alveoli are like firm, elastic little balloons that naturally snap back after you inflate them. But in emphysema, that elasticity is just gone.
Oh, wow.
Yeah, you end up with fewer, larger, just floppy sacs. So the air goes in, but because the lungs have lost their elastic recoil, the airways literally collapse during exhalation and the air gets trapped.
Which perfectly explains the classic physical presentation of the barrel chest, right?
Yes, exactly.
Like the patient literally changes shape because their chest wall expands to try and accommodate all that trapped, stale air.
And you also see them in what's called the tripod position.
Right, leaning forward with their hands braced on their knees because they're desperately trying to recruit accessory muscles in their neck and shoulders to just force the air out.
Yeah, it's exhausting. But then you contrast that with the other side of the COPD umbrella, which is chronic bronchitis.
Okay, how's that different?
Well, here, the primary issue isn't the destruction of the alveoli themselves, but rather severe, chronic inflammation of the airways leading down to them. The bronchial tubes become swollen with edema, and they produce just massive amounts of thick, sticky mucus.
Oh, that sounds awful. So that's where the wet cough comes from.
Exactly. The hallmark symptom is a chronic, highly productive cough. Clinically, these patients are often referred to as blue bloaters.
Blue bloaters, that's a very descriptive term.
It is. The blue indicates cyanosis, so a bluish tint to the skin and mucous membranes, because that mucus plugging is preventing adequate oxygenation. And the bloater refers to the fluid retention and right-sided heart failure that eventually develops.
Because the heart is basically blowing out its motor,
Yeah.
trying to pump against that chronic lung resistance.
Seriously.
So both of these conditions create a massive physiological traffic jam.
Mm.
But the clinical notes reveal a consequence of this that is, it is absolutely mind-bending to me.
The drive shift.
Yes, because a healthy person's primary drive to breathe is actually triggered by carbon dioxide, not oxygen.
Right, which surprises a lot of people.
Totally. Think of the brain's respiratory center like a thermostat. Usually the thermostat is set to detect heat, right? In this case, heat is CO2. When CO2 levels get too high in your blood, the thermostat kicks on and your brain commands your diaphragm to take a breath and just blow off that CO2.
And that mechanism works flawlessly right up until a patient develops severe COPD.
Because they can't blow it off.
Exactly. Because of all the air trapping and emphysema or the thick mucus and chronic bronchitis, these patients simply cannot exhale CO2 effectively. So over years, they become CO2 retainers.
Meaning their blood is just constantly saturated with abnormally high levels of carbon dioxide.
Right. And the central chemoreceptors in the brain that normally act as that thermostat, they eventually just become desensitized. The system essentially realizes it can't fix the high CO2, so it shifts its primary alarm system entirely.
It kind of rewires itself to react to the cold instead of the heat.
That's a great way to put it.
Yeah, so instead of breathing because CO2 is too high, the COPD patient's primary drive to breathe shifts to reacting only when oxygen levels drop too low. They develop what is clinically known as a hypoxic drive.
And understanding that shift is, it is the absolute cornerstone of nursing care for these patients because it completely changes how you administer oxygen therapy.
Okay, wait, I need to stop you right there.
Yeah.
Because if a patient comes into the emergency room struggling to breathe, visibly cyanotic, and they have an oxygen saturation sitting around, say, 88%.
Which is very low for a healthy person.
Right. Every human instinct screams, give them maximum oxygen immediately. Are you telling me that acting on that instinct could literally kill a COPD patient?
It really could. If you push a severe COPD patient's oxygen saturation up to a normal 98%, you run the risk of completely suppressing their hypoxic drive.
Oh, wow. Because their brain senses all that oxygen and thinks the emergency is over?
Exactly. It assumes they're fine and simply stops sending the signal to breathe.
That is terrifying.
It is. This is why the nursing process mandates, starting with very low flow oxygen, typically just 1 to 2 liters per minute via nasal cannula, you are constantly walking a clinical tightrope.
Because you have to provide just enough oxygen to prevent tissue hypoxia, but not so much that you knock out their only remaining physiological trigger to breathe.
That's it, exactly.
That is such a narrow window for intervention. It makes you realize why accurate diagnostics are so critical here. Like, we can't just look at a barrel chest or a blue tint and guess at the severity of the air trapping.
No, you need objective data. To definitively prove what's happening mechanically inside those lungs, providers rely on pulmonary function tests, specifically the gold standard, which is spirometry.
Okay, break down the math for me on spirometry.
Sure. So spirometry removes the guesswork by quantifying the airflow obstruction using a specific mathematical ratio. The two key metrics are the FVC and the FEV1.
FVC being the forced vital capacity, right?
Right, which is the absolute total volume of air a patient can forcefully exhale after taking the deepest breath possible.
Okay, and the FEV1.
That's the forced expiratory volume in exactly 1 second. It measures how much of that total volume you can blast out in the very first second of exhalation.
I get how blowing into a machine measures volume, but why is that 1 second mark the holy grail for a COPD diagnosis? Let me try to visualize this.
Go for it.
Imagine the FVC, the total lung capacity, is like a brand new tube of toothpaste.
Okay, I like this.
And the FEV1 is how much of that toothpaste you can squeeze out in one single forceful squeeze. If your lungs are healthy and elastic, you can empty most of that tube immediately, right?
Yes, very quickly.
But for the COPD patient where the alveoli are floppy and lack recoil, does the toothpaste just, get stuck at the bottom?
The visual holds up perfectly. Mechanically, what's happening is that without the elastic tethering of healthy tissue, the airways prematurely collapse under the pressure of a forced exhalation.
So they literally squeeze themselves shut.
Yes. It is physically impossible for them to get the air out quickly. Therefore, their FEV1 plummets. The diagnostic criteria state that if the ratio of FEV1 divided by FVC falls below 70%, you have a confirmed clinical diagnosis of COPD.
And I'm guessing the lower that FEV1 number drops, the more severe the air trapping is.
Exactly. It dictates the disease progression.
This concept of air trapping, it isn't just for the lab. It is super central to patient education.
Oh, absolutely.
There is a specific Q&A scenario in the clinical notes that highlights this. A nurse is educating a COPD patient, and the patient asks, "Why do I get so completely exhausted just walking a few steps to the bathroom?"
Which is a very common complaint.
Right. Now, for someone untrained, the instinct might be to suspect a cardiovascular issue, like maybe the heart isn't pumping efficiently enough to oxygenate the muscles.
But that would be incorrect in this context.
Exactly. The correct clinical rationale the nurse provides is your lungs trap air, making it significantly harder to breathe and get oxygen.
It is so crucial to dispel that cardiac assumption. The exhaustion comes from the sheer caloric and mechanical effort of trying to push air out of lungs that simply refuse to deflate.
It's like doing a strenuous workout just to breathe.
Exactly. And to combat this, one of the primary nursing interventions taught is pursed lip breathing.
Okay, I've seen people do this. How does it work?
The patient is instructed to inhale deeply through the nose and then exhale slowly and deliberately through tightly pursed lips. It looks exactly as if they were blowing through a narrow straw.
I understand how blowing through a straw slows your breath down, but how does that actually help get trapped air out of a floppy, collapsed lung?
It is all about manipulating airway pressures. By exhaling against the resistance of the post lips, the patient creates a positive back pressure that travels down the bronchial tree.
Oh, so it pushes back against the collapse.
Yes. This back pressure physically stents those damaged, floppy airways open just a few seconds longer. It prevents the premature airway collapse we just talked about with the FEV1.
Letting that trapped, stale air finally escape so fresh oxygen can enter. That is a brilliant, non-pharmacological mechanical fix.
It really is. It gives them control back.
No, we've been focusing a lot on chronic structural collapse damage that happens slowly over decades. But airway obstruction isn't always a slow burn.
No, definitely not.
Sometimes it's a sudden, violent, and entirely reversible explosion. And that is the fundamental difference between COPD and an acute asthma exacerbation.
Asthma is driven by a completely different pathophysiology. It is a hyperreactive immune cascade.
So it's an overreaction.
Essentially, yes.
Yeah.
When a patient with asthma encounters a trigger, which, could be pollen, cold air, pet dander, or even exercise, their airways violently constrict. This is called a bronchospasm.
Right.
And almost simultaneously, the mucosal lining of the airways becomes inflamed and edematous, which further narrows the passage.
It's a two-front war. And the clinical notes outline incredibly strict rules for the medication administration used to fight it. They draw a very hard line between two specific drugs, albuterol and fluticasone. Those are the heavy hitters, yeah.
I kind of view this like managing a fire hazard. Albuterol is the fire extinguisher. It's your short-acting rescue inhaler. You grab it when the kitchen is actively in flames, and it violently rips those airways back open.
Right.
Fluticasone, on the other hand, is a daily inhaled corticosteroid. It's the smoke detector and the sprinkler system that you leave on constantly to make sure the fire never has a chance to start.
The pharmacology backs up that analogy perfectly. Albuterol is a beta-2 adrenergic agonist. It binds directly to the smooth muscles wrapped around the airways and forces them to relax, instantly reversing the bronchospasm.
Putting out the fire.
Exactly. While fluticasone works at a cellular level, altering gene expression to suppress the immune system's inflammatory cascade. And the notes actually provide a critical patient education scenario here.
Oh, about stopping the meds.
Yeah. If a patient tells a nurse, I can stop using my fluticasone once my breathing feels better, that is a massive red flag.
Because they are turning off the sprinkler system just because there's no fire today.
Exactly. It reveals a dangerous lack of understanding about maintenance therapy. Fluticasone must be taken daily to keep the baseline inflammation at bay. Discontinuing it guarantees a future exacerbation.
Let me challenge you on the use of those corticosteroids, though.
Yeah.
Because the notes include a major clinical warning about administering systemic steroids to diabetic patients.
Yes. The metabolic fallout.
Right. If corticosteroids are so highly effective at shutting down lung inflammation, why do they wreak absolute havoc on a patient's blood sugar?
Well, systemic medications rarely respect the boundaries of a single organ system. Corticosteroids essentially mimic the body's severe stress response.
It's the fight-or-flight response.
Exactly. When the human body perceives a massive threat, one of its primary survival mechanisms is hepatic gluconeogenesis.
Which means?
The liver rapidly dumps stored glucose into the bloodstream to provide immediate energy for a fight-or-flight scenario.
Oh, wow. So if you give a diabetic patient high-dose steroids to open their airways, you are artificially triggering that massive glucose dump.
Precisely. And a thorough nursing assessment must anticipate this. A diabetic patient presenting with an asthma attack will likely require temporary sliding scale insulin coverage, even if their diabetes is normally just diet controlled.
You cannot just treat the lungs, you have to manage the whole patient.
Always.
And if that initial inflammation goes untreated, or say the patient doesn't respond to the albuterol, we escalate to a terrifying clinical emergency. Status asthmaticus.
Status asthmaticus is an acute exacerbation that is completely refractory, meaning unresponsive to standard bronchodilator therapy.
So the rescue inhaler does literally nothing.
Exactly. It is a life-threatening medical emergency. You will see extreme tachypnea with respiratory rates shooting past 30 breaths per minute and severe accessory muscle use.
Just struggling for every single breath.
Yes. But the critical nursing assessments here actually involve neurological and cardiac monitoring.
Wait, why? Oh, because the lack of oxygen starts shutting down the rest of the body.
Precisely. If a patient becomes restless, confused, or shows an altered level of consciousness, that is a glaring sign of cerebral hypoxia. The brain is starving.
And the heart.
Initially, the heart will try to compensate by beating faster, which is tachycardia. However, the most ominous clinical sign, the one that indicates impending respiratory and cardiac arrest, is bradycardia.
Heart rate slows down.
Yes, if the heart rate suddenly drops, it means the myocardium itself is too profoundly hypoxic to continue pumping. At this stage, the nursing priority is preparing for immediate intubation and transfer to the ICU.
Man, things escalate so quickly.
Yeah.
So far, we've explored what happens when lungs lose their elasticity and what happens when the smooth muscle spasms and swells. But what happens when the most powerful medications in the world can't even reach the lungs because the airway is physically plugged with fluid?
That is a whole different ballgame.
Right. This brings us to a critical pediatric scenario in the clinical notes. RSV, or respiratory syncytial virus.
RSV is a highly contagious virus that is notorious for causing bronchiolitis in infants. The infection triggers an overwhelming production of thick, copious secretions.
Just tons of mucus.
Tons of it. And to understand why this is so uniquely dangerous, you have to understand the specific anatomy of a neonate. Infants are obligate nose breathers for the first few months of life.
Meaning they literally don't know how to breathe through their mouths yet.
Right. Their anatomical structure, they have a large tongue relative to their oral cavity, and their larynx sits high up. It makes mouth breathing incredibly difficult, especially while they're trying to feed.
So if their nasal passages are completely occluded with mucus, they literally cannot figure out how to bypass it.
Exactly.
Which sets up an intense prioritization case study in the notes. A 2-month-old infant presents to the emergency department with RSV, copious nasal secretions, severe retractions, and difficulty feeding. The nurse has to rank their immediate actions.
This is a classic board-style question.
Yeah. The options provided are: instill saline drops and suction the nares with a bulb syringe, place the infant in a mist tent with oxygen, or administer a nebulized bronchodilator.
This specific scenario tests the fundamental core of the nursing process and emergency prioritization.
I have to admit, looking at those options, it feels incredibly counterintuitive.
How so?
Because human instinct, especially when looking at a 2-month-old baby who is visibly struggling to breathe and potentially turning blue, is to immediately reach for the oxygen mask. It feels almost negligent to delay giving them oxygen just so you can use a little rubber bulb syringe.
It does feel wrong, doesn't it?
Yeah. In a real-world clinical setting, do you truly withhold oxygen to suction first?
You absolutely suction first, without hesitation. And here is the physiological rationale. The nursing prioritization matrix dictates treating the airway before breathing and breathing before circulation. The ABCs.
Airway comes first.
Always. If the infant's nasal airway is physically plugged with a solid wall of thick, tenacious mucus, slapping an oxygen mask over their face accomplishes absolutely nothing. Wow, okay.
It is the equivalent of trying to pour water into a bottle with the cap still screwed on tight. The oxygen simply cannot penetrate the obstruction to reach the lungs.
That makes so much sense when you frame it like that.
The paramount priority is clearing the mechanical blockage. You instill the saline drops to thin and loosen the mucus. You suction it out with the bulb syringe, and only then do you assess the need for supplemental oxygen or nebulized medications.
Airway always dictates breathing. And once that airway is clear, the notes highlight a universal baseline intervention for literally any patient experiencing respiratory distress, regardless of their age or diagnosis.
Oh yes, the simplest intervention of all.
Before you even reach for your stethoscope, you change the physical positioning.
You elevate the head of the bed.
It seems almost too easy.
It is simple, but it relies on basic gravity. When a patient is lying flat, the abdominal organs actually push up against the diaphragm, which restricts its downward movement.
Right, they get in the way. Exactly. By sitting the patient upright in a high Fowler's position, gravity pulls those organs downward. This drops the diaphragm, massively increasing the intrathoracic space and allowing for maximum lung expansion with minimal muscular effort.
It is brilliant how much of respiratory medicine really just comes down to manipulating physical space and pressure.
It's basically physics.
And that brings us to the final major clinical interventions we are exploring today. Managing the physical pressure surrounding the lungs themselves with chest tubes, and managing the physical environment of an infant with SIDS prevention. Let's look at the chest tubes first.
Okay, so to understand chest tubes, you first have to understand the pleural space.
Yeah.
This is the microscopic cavity between the outside of the lung and the inside of the chest wall.
Like the space between two panes of glass.
Exactly. Normally, this space contains negative pressure, which acts like a vacuum to keep the lung pulled open and inflated against the ribs.
Got it.
If atmospheric air enters this space, which is a pneumothorax, or if blood or fluid pools in there, that negative pressure is lost and the lung collapses inward.
So a chest tube is surgically inserted to drain that foreign air or fluid and basically reestablish the vacuum.
Exactly right. Apical placement, high up on the chest, is used for air because air rises. Basilar placement, lower down, is used for draining heavy fluids like blood.
And the genius of the chest tube drainage system is the water seal chamber, right? Because it acts as a one-way physical valve.
Yes, it is filled with sterile water. As the patient exhales, the trapped air in their chest is pushed down the tube, bubbles through the water, and escapes into the room.
But when they inhale, the water prevents atmospheric air from being sucked backward into the chest cavity.
It's a perfect physical barrier. But here is the critical nursing intervention scenario. What happens if that tube gets violently yanked out of the patient's chest wall?
Which I imagine happens when confused patients pull on lines.
All the time. The clinical directive is absolute. You never attempt to reinsert a dislodged chest tube yourself.
Because it's a sterile surgical procedure.
Right. But more importantly, if that tube comes out, you now have an open hole directly into the pleural cavity, and with every single breath, the patient will suck room air into their chest, rapidly collapsing the lung.
So what do? Just cover it with your hand.
The immediate nursing intervention is to slap a sterile petroleum gauze dressing over the insertion site. But, and this is vital, you only tape it securely on 3 sides.
Yes. The physics behind this 3-sided tape trick is fascinating. By leaving one side completely untaped, you are essentially building a makeshift exhaust valve right on the patient's skin, right?
Precisely. When the patient forcefully exhales, the increased positive pressure inside the chest pushes that untaped flap of the dressing open, allowing any trapped air to vent out.
Oh, that's brilliant.
But the moment they inhale, the negative pressure immediately sucks the petroleum gauze completely flat and airtight against the skin.
Ew.
It physically seals the hole and prevents any outside air from entering.
That simple application of medical tape literally prevents a fatal tension pneumothorax.
It's one of my favorite nursing hacks. It saves lives.
Which perfectly sets up our final topic, sudden infant death syndrome, or SIs. Because just like that 3-sided dressing, preventing SIs is entirely about recognizing how simple physics and positioning can dictate an airway.
The safe sleep guidelines for infants under 6 months are rigid for a reason.
Let's review them. The infant must be placed flat on their back, on a firm mattress. There should be absolutely nothing else in the trib. No loose blankets, no crib bumpers, no stuffed animals.
You use a fitted sleep sack for warmth.
Right. And the clinical notes provide a scenario to test a parent's true understanding of these environmental controls. If a parent tells a nurse, "We are going to let our baby sleep in her car seat at night because she seems to sleep so well in there," that statement requires immediate clinical intervention and extensive re-education.
It is a huge, huge danger.
I would imagine a lot of parents think that if a car seat is safe for a moving vehicle, it, must be safe for a crib. But it comes down to the anatomical differences we discussed earlier, doesn't it?
It does. A car seat forces the infant into a semi-upright angled position. Infants have disproportionately large, heavy heads, specifically a prominent occiput at the back of the skull, and extremely weak neck muscles.
Right. They can't support themselves.
So when they fall asleep in an angled car seat, gravity causes their heavy head to loll forward, dropping their chin directly onto their chest.
And because their airways are so soft and cartilaginous.
That specific position physically kinks the trachea exactly like bending a garden hose. It leads to silent, mechanical asphyxiation. Safe sleep dictates a completely flat surface to maintain a neutral, unkinked airway.
Wow. So what does this all mean? We have journeyed from the microscopic gas exchange failing across the alveoli to the massive prioritized actions of clinical providers. We've seen how to decode the math of spirometry, how a simple piece of tape can recreate pleural pressure, and why suctioning a newborn's nose always trumps reaching for the oxygen mask.
Ultimately, the entire clinical foundation rests on a deep, unyielding respect for the mechanics of respiration.
Yeah, you have to respect the machinery.
Absolutely. Whether you are a nurse treating a COPD patient who has shifted their entire respiratory drive, or a parent ensuring an infant's airway remains perfectly straight, the golden rule of the nursing process remains the same. You must protect the physical airway above all else, and you must understand the underlying physiological drive that keeps the breath moving.
That is so true. And that leaves us with one final, kind of fascinating thought for you to ponder. We spent significant time today exploring how a COPD patient's body adapts to chronically high carbon dioxide by completely rewiring their central chemoreceptors.
The drive shift.
Right. They shift their internal thermostat to rely on low oxygen to survive. It is an incredible evolutionary workaround happening in real time within a single human body. But it makes you wonder about the macro level.
Oh, I see where you're going with this.
As global air pollution continues to worsen and baseline atmospheric CO2 levels subtly but continuously rise across the entire planet, how might the respiratory drive of the average healthy human adapt over the next few generations?
Will our collective internal thermostats eventually be forced to shift, just like the patients we treat today?
Exactly. It's a profound question about the limits of human physiological adaptation.
It really is. It makes you look at every breath differently.
It does. So, the next time you take one of those 20,000 daily breaths, take a second to appreciate the fragile mechanics keeping you alive. Until next time.